and welcome to our module on cystic fibrosis. Cystic fibrosis is a genetic disorder. It is transmitted from parent to offspring in an autosomal recessive pattern, and for this reason both parents have to be carriers for a child to be affected. It results in thick, sticky mucus in the lungs and the GI tract, and we'll talk more about this in this video, and it is a common cause of chronic lung disease among children. CFTR stands for Cystic Fibrosis Transmembrane Regulator, and it is the CFTR gene that is mutated in patients with cystic fibrosis. When there is a CFTR gene mutation, this leads to abnormal production of the CFTR protein, and the normal function of the CFTR protein is to serve as a chloride ion channel. What this means is when there's a mutation and when the protein is abnormal, there will be impaired chloride transport, especially on mucosal surfaces. And chloride transport is linked to sodium transport and also to water transport. So this means that what you're going to have is mucosal surfaces without enough water because of the abnormal chloride ion channel. This will lead to thick, viscous secretions. There will be impaired mucociliary clearance in the lungs, and that will lead to lung infections. There will be impaired pancreatic secretions, which can lead to pancreatitis. And finally, the sweat will have an abnormal content of chloride, and we'll talk about this later because this is important diagnostically. Many mutations of the CFTR gene have been identified, but the most common mutation among people with cystic fibrosis is called the delta F508 mutation. It gets this name because this mutation involves a deletion of 3 DNA bases that code for the 508th amino acid in the protein product, and that amino acid is phenylalanine. This is the abnormality that is the most common mutation leading to cystic fibrosis. The pathophysiology of cystic fibrosis involves abnormalities caused by thick mucus in different organ systems. In the lungs, the thick mucus leads to recurrent pulmonary infections, especially with the organism Pseudomonas aeruginosa, and we'll talk more about this later. Thick mucus can also lead to chronic bronchitis and eventually bronchiectasis, and both of these problems can cause obstructive lung disease in patients with cystic fibrosis. In the GI tract, the thick mucus causes a number of GI problems. There's impaired flow of bile and pancreatic secretions because of thick mucus. This leads to malabsorption, especially of fats, because you need your bile acids and your pancreatic enzymes for normal absorption of fat. This can cause vitamin deficiency of fat-soluble vitamins, which are A, D, E, and K, and it can also cause steatorrhea. We'll talk later in this video about how cystic fibrosis can now sometimes be diagnosed prenatally or at the time of birth through a screening program. But if it's not diagnosed one of those ways, it's usually diagnosed before 2 years of age when children develop one of 3 typical presentations. The first one is respiratory disease, which we'll talk about in a minute. The second one is failure to thrive. Any baby that is not eating and growing and developing normally, cystic fibrosis is in the differential for failure to thrive. And the third presentation is meconium ileus, which we'll also talk about in a minute. Let's talk about the clinical features of cystic fibrosis respiratory disease. First of all, many children and adults with cystic fibrosis have a productive cough from all the sticky mucus. The sticky mucus obstructs the exit of air from the lungs and can lead to hyperinflation of the lungs on chest x-ray, and usually an obstructive pulmonary disease pattern will be present on pulmonary function testing. Later in the disease, patients can develop chronic bronchitis and also bronchiectasis, which I'll talk about in another video. The hallmark of cystic fibrosis respiratory disease is acute exacerbations, where a patient's respiratory status abruptly gets worse compared to baseline. This is believed to be related to bacteria, and the 2 key pathogens for patients with cystic fibrosis are Pseudomonas aeruginosa and Staph aureus, including MRSA. Now, it's unclear exactly how these bacteria cause the infections. Most airways of people with cystic fibrosis are actually colonized by these bacteria, and the bacteria are present even outside of exacerbations. But nevertheless, it's thought that the bacteria play a role, and antibiotics to cover these bacteria are essential in treating patients who have an exacerbation of cystic fibrosis respiratory disease. Patients with cystic fibrosis can develop chronic pancreatitis. Because of the chronic pancreatitis, they can develop cystic fibrosis-related diabetes. Basically, the pancreas gets burned out from chronic pancreatitis and therefore no longer makes insulin. You need your pancreatic secretions to absorb fat, so fat malabsorption can occur. And the classic feature of fat malabsorption is steatorrhea. These are frequent stools that are foul-smelling. They can be oily or greasy, and the patient may report that they float in the toilet bowl. If your pancreas isn't working normally, you won't be able to absorb fat-soluble vitamins normally, like vitamins A, D, E, and K. This can lead to problems in chronic untreated cystic fibrosis. Vitamin K deficiency can lead to coagulopathy. Vitamin D deficiency can lead to the bone disease rickets. Vitamin A deficiency can lead to night blindness, and vitamin E deficiency can lead to problems like ataxia and also hemolysis. So any of these types of problems in a patient with cystic fibrosis is suggestive of a vitamin deficiency. Meconium ileus is a common way that cystic fibrosis initially presents in a newborn baby. Meconium is the first stool of a newborn, and it's normally very thick and sticky, even in children without cystic fibrosis. So when children are born with cystic fibrosis, the meconium can be so thick and sticky that the child is unable to pass the first stool. This will lead to an ileus, meaning a bowel obstruction. Basically, a plug forms from the meconium, and bowel obstruction leads to abdominal distension, vomiting, and air fluid levels on X-ray. This X-ray is an example of air fluid levels in a patient with bowel obstruction. You can see that there is an air fluid level right here in the bowel, classic evidence on X-ray of bowel obstruction, and that's what can occur when newborn babies with cystic fibrosis cannot pass meconium. The abnormal secretions of cystic fibrosis can also lead to biliary disease. Secretions in the biliary tract can also become thick and sticky. This can lead to bile duct obstruction. When your bile ducts are obstructed, your stool will not have a normal color, and instead of appearing brown, they will be pale or clay colored. There can be elevation of the liver function tests, and the liver can become enlarged, and over time, this can potentially lead to cirrhosis. And anytime biliary flow is obstructed, that can lead to an imbalance between cholesterol and bile salts, and that can lead to gallstones precipitating in the gallbladder. Infertility is a common problem in patients with cystic fibrosis. In particular, it's a problem for males. 95% of males with cystic fibrosis are infertile. The reason for this is usually because of abnormal development of the genitourinary tract. Most men with cystic fibrosis have an absent vas deferens. This means spermatogenesis is normal, but the sperm cannot travel normally into the ejaculatory duct. These men can have children, but they require assisted techniques to get the sperm to fertilize the egg. Females also have a decreased fertility, but it's not as severe as men. This is believed to be due to abnormalities of cervical mucus. Digital clubbing is a classic feature of cystic fibrosis, especially patients with respiratory disease. Digital clubbing refers to a puffiness and abnormal curvature of the fingernail beds, like shown in this picture. There are a number of causes of digital clubbing, but cystic fibrosis is one of them. Some of the other common causes are lung cancer, pulmonary fibrosis, and congenital heart disease. Let's talk about the diagnosis of cystic fibrosis. The main diagnostic test for cystic fibrosis, if you suspect a patient has the condition, is called the sweat chloride test. The idea here is that the sweat among patients with cystic fibrosis has an abnormally high chloride content. So if you can measure the sweat and determine the chloride content, that can be an evaluation for cystic fibrosis. The sweat chloride test is done through a technique called pilocarpine iontophoresis. So pilocarpine is a muscarinic agonist, and it will stimulate the production of sweat from the skin. So a gauze soaked in pilocarpine is placed on the skin, and an electrode is placed over the gauze. Then a small electrical current is applied, and this drives pilocarpine into the skin and causes sweating to occur. The sweat is collected on filter paper, and the chloride content is analyzed. And a high chloride level suggests cystic fibrosis. And if the level is sufficiently high, this is enough evidence to make the diagnosis of cystic fibrosis. DNA testing is often done, although that is to determine the underlying genetic mutation. The sweat chloride test itself proves the diagnosis of cystic fibrosis. Now, there are rare patients who actually have cystic fibrosis, but their sweat test is negative. These patients usually have milder disease. They often have recurrent pulmonary and sinus infections, but nothing more than this. There is a second test that can be used if you suspect a patient has cystic fibrosis despite a negative sweat test, and that's called measurement of the nasal transepithelial potential difference. This is done only if symptoms are highly suggestive after a negative sweat test, and the way this test is done is it's a measurement of the nasal voltage across the mucosa of the nasal passages. This will be abnormal in patients with cystic fibrosis. They will have a more negative voltage because of the abnormal sodium and chloride processing. So in a board question, if they describe a patient who really looks like they may have cystic fibrosis, but the sweat test is negative, this is the test that should be done next. Let's talk about the treatment of cystic fibrosis. Many of the treatments for CF are aimed at promoting clearance of those thick airway secretions. One of the commonly used options is called inhaled DNase. It's also called Dornase alpha. This is an enzyme that breaks up long strands of DNA found in mucus. These strands come from dying neutrophils, and they cause the mucus to be more sticky. So if you break up those long strands of DNA, the mucus will become less sticky and more mobile. Another option is inhaled saline. This basically moistens the mucus and allows it to be more mobile. And then finally, chest physiotherapy is a form of physical therapy where the therapist claps or pats on the patient's back to try and promote the movement of airway secretions. Ivacaftor is a drug called a CFTR modulator. What ivacaftor does is it directly modifies chloride ion flux in the abnormal CFTR proteins. This drug can only be used on patients with specific mutations, so you must know
what the specific mutation is to determine whether or not the patient is a candidate. Exacerbations of lung disease are treated with appropriate antibiotics. They must cover Pseudomonas and Staph aureus. And then finally, for some patients, they ultimately progress with severe lung disease, and lung transplantation can be an option.
Some other treatments are shown in the slide. Pancreatic enzyme replacement is essential. Supplementation of vitamins A, D, E, and K, the fat-soluble vitamins, is essential. And finally, vaccinations, especially for influenza and strep pneumo, are very important.
I'll finish with this slide and mention screening for cystic fibrosis, which is the way that many children in the U.S. are identified. First of all, prenatal screening is offered to many parents. The parents can be tested for 23 of the most common cystic fibrosis mutations in the U.S. Remember that both parents must be carriers to have an affected child, and often the mother is tested first, and if she does not carry any of the mutations, then testing is stopped because there's no way that the mother can have an affected child in that case. Newborns can also be screened by measuring the blood level of what's known as immunoreactive trypsinogen, or IRT. This is a product of the pancreas, and in babies with cystic fibrosis, it becomes abnormally high in the blood, and therefore you can do a blood test, and if the level of IRT is high, then the baby can be sent for a sweat test to look for cystic fibrosis. And that concludes our video on cystic fibrosis.